Hello, everyone. Assalamu alaikum wa rahmatullah. Good evening, Monica. How are you, my dear?
Fine, ma'am. Thank you, ma'am.
How's study and preparation?
I'm going on. It's going on, ma'am.
Okay.
Thank you,
Best
ma'am.
of luck. Best of luck, inshallah, in the exam.
Thank you, ma'am.
So today our session would be regarding the intrapartum CTG. It's very important just to highlight the differences between the old one and the recent one. Why? Because in the exam, you may face the CTG in different situations. For example, the teaching station, the CTG, or to have the CTG in the management of delivery. For example, to give you one CTG and you have to categorize this CTG and to tell the patient, or if it's structured discussion with the examiner, to tell what about your action regarding this CTG. So what you have here in the in the recent guideline, that we may offer fetal monitoring on personal preference. For example, the patient will request to have this CTG in the delivery. So this is first change here, that we may offer the CTG on it's like decision in her personalized care plan. Okay. And throughout the labor, we will provide the woman with information on the fetal monitoring method being advised and the reason for this advice. For example, you will offer CTG. Why we will offer CTG here? This pregnancy was a high-risk pregnancy, or we have any changes with the intermittent auscultation, so we need to offer this patient a continuous CTG. Okay? We need to document everything, the decision, and what about the outcome in the patient notes, all these in the new guideline. What about the indications for continuous CTG? Either it's like personalized decision, as we mentioned in the previous slide, or we have any problem with the mother herself, risk in the mother or risk in the baby. So we will offer continuous CTG monitoring to women in labor if it's in their personalized care plan. So this is the first indication. Or we have any antenatal maternal risk factors like previous cesarean section, any hypertensive disorder, hypertension or preeclampsia, prolonged rupture of membrane, more than 24 hours. At this time, this is a risky pregnancy and a risky delivery as well. Any vaginal blood loss other than a show. So if it's only the show, no problem about it. But if we have significant blood loss, or not, it's not necessary to be significant, any vaginal loss. So we need to offer this patient CTG, any suspected chorioamnionitis or maternal sepsis, pre-existing diabetes type 1, 2, or gestational diabetes. So first indication, it's personalized care plan. This is number one. Number two, any antenatal maternal risk factor. So put any risk factor. Any pregnancy, we will consider it a risky pregnancy or high-risk pregnancy. So we will offer this patient or this lady during the delivery continuous CTG, like previous cesarean section, hypertension, previous diabetes type 1, type 2, or gestational diabetes, prolonged rupture of membrane, any vaginal blood loss, or suspected chorioamnionitis. The third indication will be antenatal fetal risk. So what about the fetal risk here? Non-cephalic presentation, including the breech, transverse, oblique, and cord, but for sure for cord we have a different. It's like emergency, and we need to have like a quick reaction or to deliver this patient as soon as possible. Number two will be fetal growth restriction below the third centile, small for gestational age, advanced gestational age, more than 42 weeks, so prolonged pregnancy. Now, one of the indications to have continuous CTG. Polyhydramnios or anhydramnios, reduce the fetal movements for sure before the onset of the contractions. So it's a very important indication. So again, three indications. If it's like personalized care plan, maternal risk, fetal risk. For the fetal risk, what about the indications here? Non-cephalic presentation, fetal growth retardation, small for gestational age, prolonged pregnancy more than 42 weeks, and any problem in the amniotic fluid, polyhydramnios, anhydramnios, oligohydramnios, and reduce the fetal movement, but it has to be before the onset of the contraction. We will offer continuous CTG. Now, the risk factors was antenatal. So we know that this patient high risk during her antenatal care. But now we have also some points or some indications during labor itself. So now we have like low risk pregnancy, and we offer this lady intermittent auscultation. And if one of these problems happen during the process of the delivery, so we need to offer this patient continuous CTG. So what about these points here? Contractions that last more than or longer than 2 minutes, okay? Or 5 or more contractions in 10 minutes. Because if we have like increased contractions, 5 in 10 minutes or more, this will affect the blood supply to the baby or to the placenta. So it will be risky. If the contraction itself lasting more than 2 minutes, it's a prolonged contraction, so it will affect the blood supply as well. So at this time, if we have problem in the contractions like that, so we need to offer the patient continuous CTG. Presence of meconium, for sure, this is a risk factor during the delivery. Maternal pyrexia, if the patient has a temperature 38 or more, single reading, or 37.5, 2 readings, consecutive, and it has to be 1 hour apart. So it's not important the details. If it's maternal pyrexia, so we will offer the patient CTG. Suspected chorioamnionitis, if we have rupture of membrane and now the patient start to have a high temperature or pain or anything, so we need to offer her, or even you suspect that this patient start to have chorioamnionitis, so we need to offer her continuous CTG. Pain reported by the woman, but it's not the contractions, it's different or apart from the contractions, to differ from the pain normally associated with the contractions. Especially if we have the patient with cesarean section from the start, we'll offer her CTG, but take care, some women will refuse that. So if we have a previous cesarean section and the patient starts to have pain and it's not like the contractions pain, so suspect uterine rupture. And the first sign to diagnose uterine rupture is CTG changes. A very famous question in part 2. So take care that CTG changes. This is the first sign of uterine rupture. Even without cesarean section, a woman can have like a uterine rupture. Yes, maybe this woman with a myomectomy before, or even without any pelvic surgery or any uterine surgery, but she may have this uterine rupture. Okay, especially if this patient, for example, with polyhydramnios or any problem like that, so it would be like over distended uterus, and this will increase the risk of rupture. So take care about the pain that's different from or differ from the pain of the contractions. What else here? Fresh vaginal bleeding develops in labor. During labor, this patient starts to have bleeding, so we need to offer her CTG. Blood-stained liquor as well. Maternal pulse over 120, okay, on 2 occasions. So this is an indication here. Severe hypertension, single reading, systolic 160 or more, or 2 readings 140, and it has to be 30 minutes apart. So we have here the severe hypertension here, or hypertension, it's 140, but in 2 consecutive occasions or readings. 2 plus protein on urine analysis, okay? And a single reading of either increased systolic blood pressure or diastolic blood pressure. So we need the protein, and with single reading of increase in the blood pressure, either the systolic more than 140, diastolic more than 90. Confirmed delay in the first or second stage of labor. At this time, we will need to offer this patient continuous CTG. Insertion of regional analgesia. the epidural, one of the indications. Use of oxytocin, one of the indications. Actually, all these indications in the intrapartum or during labor, all these indications was in the previous guideline. Okay, the NICE guideline, intrapartum care. So it's the same. So just to summarize, what about these indications during the delivery? Anything abnormal happened, like vaginal bleeding, meconium, increase in the blood pressure, increase in the temperature, presence of protein with the high blood pressure, insertion of the epidural, use of oxytocin, anything abnormal will happen during the delivery. So this is an indication to offer this patient a continuous CTG. Features of the CTG. So now we need to comment on 4 features. And these 4 features, the comment, we will give classification of each feature and then categorization of the whole CTG. So the four features are contractions, baseline fetal heart rate, variability, decelerations. And here we will face the second change in this recent guideline, that in the old one, we have reassuring, non-reassuring, or abnormal. So now we will change it into white, amber, and red. So we need to comment on the contractions. It's white or amber. The baseline heart rate, it's white, amber, or red. Variability, white, amber, or red. Decelerations, white, amber, or red. And then we will calculate how many here white, how many amber, how many red, then give the categorization of the CTG. Okay? And I think this is from my point of view that they changed this white, amber, and red because it's here in UK, it's easy to deal with the colors instead of reassuring, non-reassuring, abnormal. Sometimes maybe someone will be not familiar with these terms, but when you will tell anyone that we have here like the variability is red, okay, the classification of the variability is red. So the red color is something, means that we have something or to have some concerns regarding this feature. You got my point? So it's only just to make it a little bit easy to deal. But actually, this is also my opinion that the changes in a little bit, it's not, the previous one was a little bit easier, okay, with the tables and everything. However, using white, amber, and red, it's easier in the daily life, okay, in the labor ward to deal with with anyone to tell that we have here amber or red. So now we have concerns and we need to think. But sometimes reassuring, non-reassuring, abnormal, it's not familiar, okay? Accelerations, we will not comment on the accelerations. If it's present, it's good. If it's absent and nothing abnormal in the 4 features, so no concerns here regarding the accelerations, okay? Number 1, contractions. We will check the contractions. We need to check the frequency and the length. So we need to check how is the frequency, 3 in 10 minutes, 4 in 10 minutes, and the contraction lasting for 40 seconds, for example. So it's okay now. We will give the contractions 2 colors only, the white, amber. White, fewer than 5 contractions in 10 minutes. So it's white. Amber, if it's more, 5 or more, and if there is reduced resting time between the contractions. This is the point I commented on the first slide. So because while contractions happen, the blood supply to the baby is affected. So the baby need like resting time for recovery, for the blood supply to going back to normal. So if we have like a reduced resting time, this will affect the baby for sure. So we need only less than 5 contractions in 10 minutes. If it's 5 or more, so now we are here in this classification, or the feature will be amber at this time. Baseline fetal heart rate. So now we have white, amber, and red. White, this is the reassuring in the old guideline. If the baseline between 110 to 160. So now this is reassuring in the old, and now in the new it will be white. What about the amber? If there is any increase in the baseline heart rate of 20 beats a minute or more. So this is the third difference here, guys. So for example, the baseline for this baby is 100. One second, please, just to admit people here. So for example, we have this baseline of the fetal heart rate, and it's around 130. So now this basal heart rate jumped up to 160, okay, or 159, just to be in the white. So still it's in the white, yes, but what happened that the increase is 29 beats per minute. So at this time, the increase more than 20, so we are here in the amber, okay? So any increase more than 20 beats per minute or more from the start of labor or since the last review and 1 hour ago. So the last review of the CTG. This is the first change here in the basal heart rate. That's next, 102, 109. So 100 to 109. So this is amber. Unable to determine the baseline. Okay, so if you are not sure, there is a lot of decelerations and the heart rate coming up and down, so you are not sure about the baseline heart rate. This is also a new feature here. So this is amber. Okay. The red, if the heart beats less than 100 or above 160. So if it's less than 100 or more than 160, so at this time, it will be red. Okay, so the main changes here in the amber regarding the increase in the 20 beats per minute from the baseline or from the start of labor or from the last review, and unable to determine the baseline. So now we can classify the fetal heart rate. This fetal heart rate, white, so nothing to worry about. Amber, we have some concern. Red, no, now we have a major problem or a big concern, and we need to take action and to implement some changes to this woman and then check her again. Variability. We have here also many differences in the variability, not like the old one. So what is the meaning of variability? Variability is the change in the fetal heart rate in 1 minute. So for example, if we will record for 1 minute, and this is the fetal heart rate is going like this. Okay, so it's like between 1 second, guys, just I will admit people here. Okay. So if we have this basal heart rate and it's between 130 and 140. So what about the variability here? It's 10. This is 1 minute, and the difference between the lowest fetal heart rate and the highest one is 10. So this is normal, this is white. If the variability 5 to 25 beats per minute. So, and this is like the old one. Okay, coming to the amber. If it's fewer than 5, for between 30 and 50 minutes, or more than 25 for up to 10 minutes. This is the second or the first difference here in the variability. Okay, so I will tell you the differences in each feature. Okay, so in the old guideline, it was 10 to 25 minutes. But here it's up to 10 minutes only. We will not leave the variability to be more than 25, more than 10 minutes. For example, the fetal heart rate, it's like this, 130 and then 160 in the same minute. In the same minute. So this is increased variability. If it will be up to 10 minutes, so it's amber. If it's more than 10 minutes, what we will do, we will move here to the red. If it's more than 10 minutes. So again, what about the amber here? If we have less than 5 or more than 25, we have the normal values, 5 to 25. So if less than 5 for 30 to 50 minutes, this is amber. If it's more than 25 for up to 10 minutes, this is amber. So if it's fewer than 5 beats, we will move here. It's more than 50 minutes, we will move to red. If it's more than 25 for more than 10 minutes, so we will move also to red. You got the point? So just know the normal, and then for how many minutes we can apply this changes. If it's fewer than 5 minutes, but the time between 30 and 50 minutes, it's amber. More than 25, 10 minutes, it's amber. If we will increase the timing here more than 50 minutes, we will go to red. If we increase more than 10 minutes, we will go to red. So it will be easier to remember. And the sinusoidal. This sinusoidal will be less variability. It's like tooth-like. And what about the most common cause of this? The famous question. The sinusoidal. What about the most common cause? Anyone?
Ma'am, hypoxia. Fetal hypoxia.
Fetal hypoxia. Fetal anemia. Fetal anemia. Very well done, Sadia. Very well done, my dear. Any fetal anemia, fetal hemorrhage, so it will lead to sinusoidal pattern. My second famous question, so I will ask you all my questions now. So my second famous question, what about the difference between the classification and the categorization? Differences between classification, so how can I classify the CTG and how can I categorize the CTG? Anyone? Okay, so as we mentioned, the features, we will give the classification, white, amber, red. So the classification will be white, amber, red. And we describe the classification of the features like variability, like the basal heart rate. So classification of a feature, only one feature of the CTG. And in the old guideline, as we mentioned, it was reassuring, non-reassuring, abnormal. And we replace it now with these three terms. What about the categorization? This is categorization of the whole CTG.
Normal, suspicious, and pathological. No? NSP.
Yes, very well done, Monica. And suspicious and pathological. So we will count the white, amber, and red. If it's all white, so we can tell this categorization is normal. If we have one amber, at this time, it's suspicious. If we have two amber or one red, so it will be pathological. You got the point? So this is the difference between classification and categorization. You need to know that because in the teaching station, you need to tell the ST1 about the classification, how to classify and how to categorize, because you will have the CTG in front of you. First, tell the ST1 about all the normal features. We need the basal heart rate to be in this, variability that, and decelerations. And then comment on the classification, white, amber, and red. And then categorization, simply. All white, it will be normal. Yes, two amber, Dr. Namat. Two amber will be pathological.
It's at least 2 amber. So if there are 3 ambers, it's pathological.
Just 1 second, Dr. Namat. Look here. Any one feature is amber, not two, Dr. Namat. Okay, so this is the categorization. If all white.
No, I'm talking about pathological. You see, it said 2 or more features are amber. So if it's 2 or more amber, so if you have 3 amber, it's pathological.
No, 2 or more. So if you have 2 only, it's pathological, my dear. 2 or more. It's not more than 2. If it's more than 2, yes, it's 3 now. But it's clearly mentioned 2 or more. Take care, because
Yeah,
you know.
that's what I'm saying. So if it's 3, it's pathological.
Yeah, for sure it's pathological, but 2 also pathological, Dr. Namat.
Yes, I'm just saying if it is 3, 2, 3, pathological.
Yes, for sure. Because 2 pathological. So what about 3? For sure it's pathological. Because the
Okay,
2 is pathological. You got my point? Take care, because
yes,
here.
yes, thank you.
No worries, my dear. Because here in the guidelines, they are twisting the sentences, and they have like special speech we need to learn. So they have like the indirect speech, and they can give you the sentence like with negative, and then to reverse it. They have like a special speech to here in the guidelines. So take care. If 2 is pathological, for sure 3, 4 will be pathological, right? So it's 2 or more. 1 will be suspicious. Okay, we'll go back, guys. Okay, so we're done with the variability. Coming to the next feature, okay? Yeah, we have here, take the following into account while assessing fetal heart rate variability. The variability usually will be between 2 and 5, as we mentioned. We have sometimes intermittent periods of reduced variability. This is normal, like during sleep. Some medications may affect the variability, like opioids, but take care that if we have reduced variability with the opioids, but we have another abnormal feature or another feature with amber or red, so now it's not the opioid. So we need to take the CTG as a whole, okay? Look for other features on the CTG, like rise in the baseline fetal heart rate. So we now suggest we have another reason for this. It's not the opioid. But if it's the opioid, this patient on a pain management with opioid, and we have reduced the variability, so we can say, and everything is okay, normal, so we can say that this is because of the opioids. So we need to look at all other features, okay? Our next feature will be the decelerations. It's transient episode. So what about the definition of the decelerations? Decelerations is a transient episode when the fetal heart rate slow to below the baseline by more than 15 beats per minute, and this will last for 15 seconds. So less than, it will go down 15 beats per minute and lasting for 15 seconds or more. 1 second, please, guys. 1 second. Sorry for that. Hello, my dear. Sorry for this interruption, guys. I'm so sorry. So coming back, decelerations. What about the definition? Especially in the teaching station, you need to give definition of everything. So deceleration is transient episode with the drop or slowing down of the fetal heart rate for more than 15 beats per minute, and each episode lasting 15 seconds. So if we have reduced the variability, so now already this baby with reduced variability less than 5. So we may find a deceleration, but it will be a shallow deceleration. So this deceleration will not be 15 beats. So we can account it deceleration or not? Yes. So if we have reduced the variability, any shallow deceleration less than 15 beats, so we will count it like deceleration. And this is new in 2022. When assessing the significance of the deceleration in the fetal heart rate, consider the timing. Is it early, variable, or late? Okay, and this is usually will be related to the peaks and duration of the contraction. Duration of the individual deceleration. So what about this deceleration? For how many seconds? Whether or not the fetal heart rate returns to the baseline heart rate. Okay, so we need to take this features in the deceleration itself in account. So what about the early decelerations? What about the cause? Anyone can answer this question?
Head compression.
Head compression. Very well done, Manikam. And what about the variable?
Placental insufficiency.
No. Variable?
Compression of the cord, ma'am. Compression of the cord, ma'am.
Yeah. Very well done. Cord compression. What about the late? This one you mentioned, I think, Sadia. The late is a placental insufficiency. Okay, that's
Yes.
why this one is the risky one, the late deceleration. Okay, for the early deceleration, nothing. It's just head compression. Okay, so how we gonna say it's early, variable, or late? So if we have the contractions here, and this is the contraction, and here this is the fetal heart rate, and we have the deceleration just in front of the contraction. It's like mirror. At this time, this is early deceleration. If we have the fetal, the contractions like this, and this is the fetal heart rate, and we have the deceleration here, so this is late, which happened just immediately after the contraction finished. So this is the late. The variable will be at any place in the CTG, and it's not related to the contractions. So it's not like early or late. No problem, Nasrat. Yes, my dear, I will provide the recording, don't worry. Okay. What about, so we mentioned that we need to, okay, no problem, my dear. Yeah, you can go and I will provide you with the recording. I have like a drive for all the free sessions, so I will add it and I will share the link with all of you on the group, okay? So while assessing the deceleration, we need to consider the timing as we mentioned. So is it early, variable, late? What about the duration of the individual deceleration? Okay, the duration itself, and the fetal heart rate will return to the baseline or not. How long they have been present for, so how long the decelerations, okay, and whether they occur with the over 50% of the contractions. And this is another difference, and it was like a joke with my course candidates about the repetitive. So they change one word, but why? Leave it like the old one, and we are all familiar with 50% of the contractions, but they remove this word in the deceleration, and they replace it with the repetitive. Okay, presence of or absence of shouldering, the variability within the deceleration. Okay, and this points will take us to the concerning characteristics. So during the classification of the deceleration, we will mention with concerning characteristics or no. So what about the concerning characteristics? The deceleration will take 15 seconds. So for example, we have the fetal heart rate here, and then the deceleration and coming back. Okay, I will draw it better with all the normal features. So we have here with the deceleration, and then we will have shoulder, and then going down, and we have the variability here in the deceleration, and then shoulder, and then coming back to the baseline. Sorry, guys. Coming back to the normal. So this deceleration lasting for 15 seconds. So if we have deceleration, and then this deceleration will be like this. It's more than 60 seconds. This is concerning characteristic. Reduce the variability within the deceleration. So normally in the deceleration, you will find the variability. So if we have like this, and then the deceleration will be flat. This is another concerning characteristic. Failure to return to the baseline. So we have the baseline here, deceleration, and going back here. Failure to coming back to the baseline. So this is a concerning characteristic. Loss of previously present shouldering. So this is the shoulder. Slight increase in the baseline fetal heart rate just before the deceleration and immediately after, and then it will continue like normal. So if we have, this is the baseline, and then the deceleration like this without shoulder. So at this time, loss of shouldering here is a concerning characteristic. Okay, so we have this one ideal. This is a normal with the variability here, with the shoulder, with the variability in between, duration 15 seconds, coming back to normal, or not to normal, to the baseline. Okay, so in the old one, it was loss of shouldering. They added here previously present shouldering. Okay, so take care of that. We have 4 concerning characteristics. If it's present in variable deceleration, so it's from the name concerning characteristics. So we need to think about it. Okay. Any questions so far here in the concerning characteristics? Okay, so coming to the classification. Now you know the difference between, thank you, my dear. So now we all know the difference between the classification and the categorization. Classification, thank you, my dear Namat, thank you. So classification, white, amber, and red, and this will be for the feature. So now we will describe the deceleration. When it will be white, if no deceleration, or it's just early deceleration, or variable deceleration that are not evolving to have concerning characteristic, with no concerning characteristics. In the old guideline, they mentioned here's the timing. If it's up to 90 minutes, something like that. So now there is no timing, but it has to be with no concerning characteristics. Okay? So now all this will be white. The amber, if we have repetitive means with more than 50% of the contractions, with any concerning characteristics for less than 30 minutes. So it's repetitive with any concerning characteristic less than 30 minutes. So if it's more than 30 minutes, what I will do, I will go here in the red. So it's linked to each other. Less than 30 minutes, amber. More than 30 minutes, it's red. variable deceleration with any concerning characteristics for more than 30 minutes or repetitive late deceleration less than 30 minutes. Okay? So here, variable deceleration, sorry, I make it together. We will comment on the variable first. So repetitive variable, less than 30 minutes with any concerning characteristic, it's amber. If it's more than 30 minutes, so it's red. So if it's only variable, so it's not repetitive here, we would remove repetitive, and it's more than 30 minutes, so it's still amber. So repetitive, less than 30 minutes. Repetitive, more than 30 minutes. Variable, so it's not repetitive, it's not in less than 50% of the contractions with any concerning characteristics, so it will be amber. Coming to the late, if late, repetitive, less than 30 minutes, it will be amber. More than 30 minutes, it will be red. So it's linked also together. We will add here, I think we have question here. Repetitive, the first and second, the difference only the repetitive, the word repetitive, which means that more than 50% of the contractions, this one. Okay, this is the difference between the first and second. So just to make it a little bit easy, just to remember, so we can make like we have here 3 features and here 3 features. Okay, we have 2 linked together. If it's repetitive, it means more than 50% of the contractions with concerning characteristic less than 30 minutes, so it will be amber. If more than 30 minutes, I will go to red. Then repetitive late deceleration less than 30 minutes, we will be here in amber. If it's more than 30 minutes, we will go to red. So now we have the first related to the first here in red. The first related to the first. The third here related to the second. Okay, and we have one extra here, which is the variable deceleration, but it's not repetitive. More than 30 minutes, it will be amber. And we have here acute bradycardia or single prolonged deceleration lasting 3 minutes or more. Just I'm trying to make like connections between these lines just to be easy to memorize. Do you want me to repeat this again or it's clear now? Is it clear or do you want me to repeat? Just write in the chat box or just open the mic and speak if you want. Clear. Okay, thank you so much. Because actually this is the difficult part. Thank you, my dear. This is a difficult part today. So we will classify the deceleration white, amber, and red. Okay? Accelerations. We will comment on accelerations, nothing. If it's present, it's good. It means that the baby is active. Okay, acute bradycardia. Okay. And if it's absent, but no other abnormality, at this time, I will ignore. So if no accelerations, but we have decelerations, now, no, we don't have accelerations here. Okay, and what about the definition of accelerations? It's transient increase in the fetal heart rate of 15 beats per minute and lasting 15 seconds or more. Okay, so it's typically like the deceleration, but the reverse. It's a transient increase, the deceleration transient decrease or slow down. Acute bradycardia or single prolonged deceleration lasting for 3 minutes. What about acute bradycardia? So now in the basal fetal heart rate, I will go back here. Here. If it's less than 100 beats per minute. So this is bradycardia. If we have the bradycardia acute, what is the meaning of acute? So we may have the CTG from the start, like 110 and 100 and so on. But if we have the basal heart rate 140, and suddenly this fetal heart rate 80. So this is the acute bradycardia. Suddenly reduction of the fetal heart rate. If it's from the start, it's not acute. It's from the start, we have bradycardia. We have here below 100, for example. So we have here red regarding the basal fetal heart rate. But if we have sudden drop in the fetal heart rate, more than 60 beats, this was in the old guideline, more than 60. So now I have acute bradycardia. Or to have a deceleration more than 3 minutes. So imagine that. If the deceleration lasting more than 60 seconds, this is a concerning characteristic. The deceleration lasting 15 seconds. Imagine that you have a deceleration lasting 3 minutes. So it's sudden reduction of the fetal heart rate for 3 minutes or more. So this is prolonged deceleration. You got the difference between acute bradycardia and prolonged deceleration? Clear now, RT? Is it clear?
Now clear. Yeah, ma'am. Okay.
Thank you.
Okay, thank you.
Okay, so now we will start to categorize the CTG. If we have all white, no amber, no red, all 4 features white, so we have normal CTG. What we will do, we will continue on the CTG if it's continuous CTG because of any risk factor, or if we have any concerns in the intermittent auscultation, and then we transfer the patient to CTG, and it's normal, so we will make this patient back or put her back on the intermittent auscultation again. Suspicious, any one feature, amber. Pathological, when it's pathological, if 1, red, or 2, amber, and for sure 2 or more. Okay, whenever it's 2, and even we have anything after that, so for sure it will be pathological. But the start is 2, amber. Okay. Action needed. If it's normal, I will continue the CTG unless it started because concerns in the intermittent auscultation. We see, 1 second, I will read the question. We see same concerning features, whether it's repetitive, variable, or late deceleration. No, the concerning features usually in the variable. Concerning features only in the variable deceleration. If you have late, now you have a big concern because it's placental insufficiency. So you will not look for any concerning characteristics. The concerning characteristics only for the variable. Okay, so if we start the CTG, as I mentioned, because we have some concerns in the intermittent auscultation, so we will stop now the CTG and make this patient or put this patient back on the intermittent auscultation. If it's for any other reason, so we will continue. And we need to perform a full risk assessment at least every hour and document the finding. So we will assess the patient every 1 hour. Take care of that. Okay, whenever we have any concern, and we will, 1 second, I will admit people. So whenever we have any concerns and we offer this patient continuous CTG, so even it's normal, I need to have or to give this patient a full risk assessment every 1 hour and to document every findings I will find, okay? If it's suspicious, no other concerning risk factors. So I will do a full risk assessment. I will document I will do full risk assessment and I will document everything here. Note that if acceleration is present, then fetal acidosis is unlikely. But as we mentioned, if the acceleration is not there, no problem. But with normal CTG, if the CTG, but this sentence here, because we have suspicious means 1 amber. So if we have 1 amber and we have accelerations present, so fetal acidosis is unlikely. So it's like reassuring point or feature here for me. If the CTG previously was normal, consider possible underlying cause. So if we have a continuous CTG, it was normal, and suddenly we have 1 amber, and now CTG now suspicious, so we need to search for the underlying cause. Okay, and we need to do some conservative measures, like change the mother's position, giving her oxygen, but in the old guideline, even they mentioned that the oxygen will not help a lot in that. If this patient on oxytocin and there is increased contraction, so we need to stop or to reduce the dose of oxytocin. Or if the contractions more than 5 and now there is no resting time, so we can offer this patient a treatment to reduce the contractions. So this is the conservative measures. And while doing the conservative measures, we will assess the patient. And in this guideline, it's also a new change that they are every now and then mention that take the whole situation, the CTG with the clinical situation of the mother. What about her examination? What about the risk factors? So it's not only the CTG. We will assess the patient at like a whole, not to take every part of the examination like CTG separately from the examination, from the risk factors. No, we will add it all together and assess the whole situation. If it's suspicious and we have additional intrapartum risk factors like slow progress, sepsis, meconium, we will do also full risk assessment, document, and consider underlying cause. We need to search about the cause, and we will do conservative measures. What here more than the previous slide, we will obtain urgent review by senior obstetrician or senior midwife. And we will consider at this time fetal scalp stimulation or to expediting the birth to make it like fast. If this patient, she's fully dilated with a good station and we can apply the instrumental delivery, it's okay. But it's consider, it's not offer. So take care of the differences between consider, think about, and offer. So we need to take action now. Okay. If it's pathological, at this time, we need to obtain urgent review by senior obstetrician or a senior midwife and a senior midwife. Exclude acute events. So now this CTG, especially if it was normal, suddenly it's now pathological. So we will think about cord prolapse or placental abruption or uterine rupture. And all these 3 examples need immediate intervention or immediate action. So take care of that. Perform a full risk assessment and document everything. So as you see in the normal, suspicious, pathological, full risk assessment in all patients and document everything. Consider possible underlying causes and undertake conservative measures as indicated. So we will search, we will need to obtain urgent review, then exclude acute events. If no acute events, so we will perform full risk assessment, document everything, and we will consider underlying causes and we will undertake conservative measures. And for sure, we will consider here fetal blood sampling. Okay, just to check. For the fetal blood, I will add this point here. It's not in the slide. So if the fetal blood sample, you will offer this patient fetal blood sampling. If it's normal, what we will do? Normal, borderline, abnormal. So if the fetal blood sampling, we have a pathological or any concerns in the CTG, and we offer this patient fetal blood sampling and it's normal, so no fetal acidosis, so we will repeat in 1 hour. We will repeat the fetal blood sampling and keep the patient on continuous CTG. If it's borderline, we will repeat after 30 minutes. If it's abnormal, now we diagnose fetal acidosis. So we need to deliver the baby, either by cesarean section or by instrument if the patient fully dilated and with a good station, instrumental delivery. Okay, so this is the fetal blood sampling. You can add this point, but actually, to be honest with you, in the exam there is no time to mention more and more points. Usually, even in the teaching station, you will have one CTG, and you can diagnose, for example, it's pathological, and the ST1 will start to tell you about that this patient in the labor ward now, and she's, for example, 5 centimeter dilated. So what we can do, and if you have pathological, so you will offer this patient fetal blood sampling. If it's abnormal, so we will go for cesarean section because it's 5 centimeter. So here you will not mention anything about the instrumental delivery. So it will be like a special scenario or a specific scenario in the exam. If the CTG is still pathological after implementing conservative measures, so we need another or a further urgent review. We will evaluate the whole clinical picture. It's in all guidelines, RT. It's not here specifically, but we need to offer this woman fetal blood sampling, or the baby fetal blood sampling. Okay, evaluate the whole clinical picture, and we want to see if there is any intrapartum risk factors for the fetal compromise. If we have acute bradycardia or single prolonged deceleration, so what about the action here? Here, for sure, for example, RT here, you will not offer this patient a fetal blood sampling. Okay, for the acute bradycardia, we need like to have like a fast reaction quickly. We need to either to deliver this baby or to implement some changes and to see if this acute bradycardia will disappear or not. And we have here a rule of 3, 6, 9, 12. It's not in the guideline, but we can apply. Okay, 3, 6, 9, and 12. So what we will do first, we will need urgent obstetric review. Okay, if there has been an acute event, for example, cord prolapse, abruption, uterine rupture, so we need to expedite the birth or the delivery. Consider possible underlying causes. Make preparations for an urgent birth, including a request for pediatrician to come and to assess the baby, and neonatal support for sure. Okay, so what about the rule of 3, 6, 9, and 12? Here, no time to offer this patient or the baby fetal blood sampling. So we diagnose acute bradycardia, implement some changes, urgent review, and we will assess again. This is for 3 minutes. We will assess again if it's the same situation at 6 minutes. So what we will do at 6 minutes, we will move the patient to theater. So the patient has to be in the theater in minute number 9, in 9 minutes from the start of the acute bradycardia. And in the minute number 12, so 12 minutes from the start of the acute bradycardia, the baby has to be out. You got the point? So 3, 6, 9, 12. We diagnose acute bradycardia or prolonged deceleration. So we will wait. It will be for 3 minutes. Then now we diagnose at 3 minutes. Then we will wait 6 minutes. Still the situation, move the patient to theater at 9 minutes and deliver the baby 12 minutes. Okay, 12 minutes from the start. So remember this rule, 3, 6, 9, and 12. This is the end. Any questions, guys?
So kind of you, Doctor, this is very crystal clear, and I was really, this was very difficult to understand.
Thank you, my dear.
So kind of you.
Thank you, my dear. Thank you so much. Any questions?
And ma'am, thank you so much, ma'am.
You're welcome, Manikam. Thank you, my dear. Okay, guys.
Thank you, ma'am. Thank you.
Yes, Arti?
Thank you, ma'am. It's
You're welcome.
clear.
Thank you so much. I'm very happy now because it's clear now. Thank you so much for
Yeah,
all
ma'am.
your attendance.
Yeah.
I will share the recording today, inshallah, with all of you. I will put also the PDF. So it will be very easy to revise. And I have one request from the course candidate to make like a table like the old one. I'm working on that. So if I finish the table, I will share also with you. Yeah, Dr. Heba. Yes, I can repeat it. 3, 6, 9, and 12. So if you can see here that if we have acute bradycardia or single prolonged deceleration for 3 minutes or more, so we need to wait 3 minutes to diagnose this is acute bradycardia for 3 minutes, and single prolonged deceleration, the prolonged deceleration itself for more than 3 minutes or more. So I will wait to diagnose this is acute bradycardia or single prolonged deceleration. So now this is the minute number 3. At this time, I will assess the patient and I will take obstetric review. I will exclude any acute event. I will check if there is any underlying cause. So I will reach minute number 6. And the CTG is still the same with acute bradycardia or prolonged deceleration. So at this time, because prolonged deceleration, it's a 3 or more. So maybe the baby will be in this deceleration for a long time. So at this time, I need to move this patient to the theater. So now I'm in minute number 9. Minute number 9, the patient has to be inside the theater. Minute 12, the baby has to be out with the neonatology team. Okay? So you will not be able to diagnose single prolonged deceleration unless 3 minutes passed from the start. Okay. Okay. Clear now, Heba? Okay, thank you, my dear. So 3 minutes, you diagnose, implement changes, exclude any acute event, any underlying cause, 6 minutes, move the patient to theater, 9 minutes, deliver the baby, 12 minutes. Any other questions, guys? Okay, thank you so much. One more thing, I will try to arrange again, but we need to choose the module. So on the group, just share your ideas about what about the module you need a session for that module so I can arrange. And another thing, I put this message on the group. If you need any help, any hand in any module, just text me, okay? And inshallah, I can arrange this with you, okay?
Can you arrange this one labor care guide?
The labor?
That is new. Yeah.
You
Labor
need the
care guide.
labor module or what? Sorry.
No, that is new WHO labor care guide. Na?
Cannot
It
hear
is
you.
recall.
Ma'am, the WHO labor care guide, ma'am.
Yeah, the partogram.
Yes, ma'am.
Yeah.
Okay. So we can arrange this to be the next session, inshallah. Okay?
Okay, thank you.
You're welcome, my dear. Okay, guys, we will stop here. Thank you so much for your attendance. Labor ward perturbation. Okay, Dr. Heba. Okay. So we can arrange the next session to have the partogram, the new one, and labor ward perturbation. Okay. Thank you so much. Thank you for attendance. Assalamu alaikum wa rahmatullah.
Thank you so much. Wa alaikum assalam.
جزانا وإياك دكتور نعمات. You're welcome, Dr. Heba. Thank you so much.